Obesity that cannot be controlled with diet and exercise may be corrected with surgery. Gastrointestinal surgery for obesity, also called bariatric surgery, alters the digestive process. This most often involves reducing stomach capacity and may also include bypassing some of the small intestine. There are two basic types of surgery. A restrictive operation only reduces stomach size. If stomach restriction is combined with bypassing some of the small intestine, less of the digestive tract that absorbs calories and nutrients is available for use. So these are called malabsorptive operations. The Roux-en-Y gastric bypass is a malabsorptive operation that has been used for over 2 decades. It is the most common and successful of the malabsorptive procedures. The procedure consists of creating a small stomach pouch to restrict food intake. Then a section of the small intestine is attached to the pouch to allow food to bypass the lower stomach, the duodenum, the first segment of the small intestine, and the first portion of the jejunum, the second segment of the small intestine. This procedure reduces the capacity to store, process, and absorb nutrients, but still maintains the ability to secrete appropriate gut enzymes and hormones. Complications include the risk of restrictive surgeries coupled with the risk for nutritional complications, such as vitamin and mineral deficiencies. The technique has been refined since its introduction. Now the most common procedure is a less invasive approach using laparoscopic techniques as described by Whitgrove and others. The patient is placed under general anesthesia. Very small incisions are made for the insertion of the ports or trocars through which the surgical tools will be inserted. To create the roux limb, the jejunum is first divided using staples. A rubber tube is attached to the jejunum as a handle for pulling. The length of the roux limb is determined according to the patient's BMI, body mass index. An end-to-side connection or anastomosis between the proximal jejunum and the roux limb is created by use of 2 staplers. The hole is closed by placing a row of stitches. The stomach is made into a smaller pouch using staples. The roux limb is pulled to a retrogastric position. An end-to-side connection between the gastric pouch and the roux limb is made. After opening, the connection between the gastric pouch and the roux limb is created by stapling and secured by placing a row of stitches. After testing for leakage, the surgical tools and trocars are removed and the incisions closed. Lifelong post-operative follow-up is required after bariatric surgery.